every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so pleased you could join us today. My first guest is the distinguished Dr. Christopher Meckel, board-certified orthopedic surgeon. Dr. Meckel, thanks so very much for coming on the program.
Thanks for having me.
Dr. Meckel, we're going to talk about a very important topic today, very common concern, that's joint replacement. But before we get to that, let's talk a little bit about you. Now, I understand you are board-certified in orthopedic surgery.
I am.
So, Dr. Meckel, let's explain to the audience, let's teach our audience what board certification means.
Well, board certification is a process that you go through that's sort of a standardized way of being sure you're up to snuff and you know what you're doing and that you've studied all the appropriate things and done the appropriate number of cases to go out in the world and be an orthopedic surgeon.
So similar to being board certified in plastic surgery, you have to successfully complete an approved training program, correct?
Correct. It's a 5-year program, and then you typically take your boards, your last boards, after you've been out for a year.
Okay, so you did residency in orthopedic surgery.
I did.
After medical school.
Correct.
And where did you go to medical school?
I went to medical school at USC.
USC, finally. I've had enough of these UCLA guys. Dr. Meckel, thank you for coming on the program.
Sure.
Go USC.
That's right.
So you finished medical school at USC, and you did your residency in orthopedic surgery where?
At USC.
At USC. And then how soon after your training can you get your boards?
We usually wait a year. I did a fellowship year in joint replacement, so I did an extra year of training, so that sort of delays your boards about another year. But I did that, and then I came locally and waited a year and took my boards.
Okay, so you said something very important. You did a fellowship in joint replacement surgery. Mm-hmm. Now that is training in addition to orthopedic residency.
Right, so orthopedic surgery in general, lots of different areas. There's tumor surgery, hand surgery, spine surgery, and if you want to specialize in one of these areas, then you do another year after your general training, and that's what I did with sports medicine and joint replacement.
Excellent. So similar in plastic surgery, I finished a residency and I did fellowship training in cosmetic surgery and hand surgery and microsurgery. So that's additional training in subspecialty areas.
Correct.
So that is a perfect segue to our topic today, which is joint replacement. Dr. Meckel, we know, and we want patients to know, that there are many different types of joints in the body, correct?
Absolutely.
There's, for example, the hip joint, there's the knee joint, there are joints in the vertebral column surrounding the spine, and there's even a joint in the sternum and the chest, correct?
Correct, and all of those joints are a little bit different in the way they function and the way they're treated. For example, a shoulder joint is something that has great mobility. Basketball players, the way they can move their arms and their shoulders to do all the things they do, but it inherently is a little bit unstable because it has so much mobility. The knee joint is more like a hinge, so different types of joints, and they have different functions and different limitations as well.
Okay, so I happen to do a fair number of joint replacements and joint work in the hands. Now, isn't the knee joint somewhat similar to the small knuckle bones, the small joints of the hand?
Very similar. They're both very much like a hinge in the way they function.
Whereas you were saying that the shoulder joint has a tremendous range of motion.
Right, and that's not true of the knee. The knee moves very well front to back, but you don't want to be moving your knee side to side. That's when you start to have injuries. And so it's constructed such that it's rigid side to side to a certain degree, unlike the shoulder or unlike the hip, which has a greater mobility as well. It's a ball and a socket joint, so it can move all around in multiple directions.
Okay, excellent. So that's another perfect segue for us to talk about degenerative joint disease, right? Or what we might call arthritis. Now, arthritis we could talk about for hours, of course. But how do you teach patients in your office, in summary, what we mean by arthritis or degenerative joint disease?
Well, like you said, there's so many different kinds of arthritis that you immediately have to narrow it down to one type, which is osteoarthritis. which is not osteoporosis. Osteoporosis is low density in your bones. People confuse that a lot. Osteoarthritis is just wear and tear of your joints. So imagine that we'll take a hip joint, the ball and the socket, the covering on the ball, think of it as some sort of lamination or clear coat that over time slowly wears down. The analogy is the cartilage. Over years of our lives, it slowly wears down and becomes pitted, and it becomes painful then when it's roughened and rubs against the inside the socket of the hip joint. And that's osteoarthritis.
Okay, so let's talk about the hip joint a little more. You called it the ball and socket, correct? So forming the socket and forming the ball, there's bone inside, correct?
Correct.
And then it's covered with a coating or some layers of cartilage.
Right. And cartilage is that slick material that you see if people eat chicken, and the chicken joints when you eat it, that's that white, very slick material. And as the ball sits in the socket, both the ball is covered with it and the socket is lined with it.
Okay, so if some of our viewers and listeners are mechanically minded, there are other joints that can be covered with hard silicone, like in cars or mechanical devices, correct? Because we don't want metal rubbing against metal, right. It's usually a silicone right. hard coating or even plastic or ceramic.
Right, you need to decrease the friction. So what we call that interface of the ball and the socket is the bearing surface. So what's bearing the weight? And then that's how you get into a discussion about what materials you use when you replace a hip.
Oh, good. If we have time in this brief discussion, we're going to get to there.
Okay.
But let's explain why or how someone gets degenerative joint disease leading to the option of a joint replacement or joint resurfacing.
I think probably the best analogy is treads on a tire. If you have a car that drives, or a truck that drives a certain number of miles, the more miles it drives, the more wear there's going to be on the tread. The more weight that the truck is carrying, the greater the wear. The analogy, though, breaks down a little bit when you talked about what kind of tread is on the tire, meaning what's the genetics of the person's cartilage that you're talking about. So if somebody has great genetics, they could carry the same load for the same distance and have minimal wear, whereas somebody does exactly the same thing could have greater wear. We don't understand those genetics so well, but as the cartilage wears down, it leads to pain and disability. Typically, you see people less exercise. It's very difficult after they sit for a period of time to get up and immediately start walking. They usually have to take a couple of steps and warm up a little bit, and then they can start moving.
So, Dr. Meckel, is it true that almost any joint in the body can suffer from degenerative joint disease, or is it certain joints more than others?
Certain joints do more than others, but it is true that any true joint, a joint that has a capsule and cartilage, can suffer from osteoarthritis.
Okay. Well, I'd like to let's take a few minutes to focus on the hip joint, if we could.
Okay.
And again, this is going to be one of those segments where I want to learn a lot. I want you to teach me, and then hopefully our audience will learn. I've noticed you go into the emergency room a lot, as I do
right.
on occasion, and people will come in with hip fractures. And sometimes you guys fix the bone fracture, and other times you seem to replace the joint, correct?
That's correct.
So can you summarize and teach me why you sometimes fix the fracture and other times you just replace the joint?
The underlying desire is always to keep people with their own parts. So if there's any way to take the fracture of the broken bone and fix it with some sort of metal, a plate, a rod, screws, that kind of a thing, then we'll do that. But it comes down to really engineering, I guess, or mechanical engineering as to whether you can do that reliably or not. So if we pretend that this is a femur bone, and this is the ball and the socket is here.
Okay, so the femur bone is the big thigh bone.
Correct.
I think that's maybe the biggest bone in the body, isn't it? Or
yep.
one of the biggest bones.
It is, yep.
So the femur is the thigh bone,
mm-hmm.
and that serves at the top of it is the ball.
Correct, and then your pelvis has the cup that the ball fits in. And when someone breaks their hip, typically that fracture can be down here, down low. And if it's low enough, then you have enough room to put in a metal rod or a plate on the side of the bone and fix it with screws. But as that fracture gets closer and closer to the ball, to the end of the ball where it fits in the cup, you really don't have enough bone to work with to fix it well and reliably. So in that case, then typically what you do is you remove the fractured portion and you do a partial hip replacement.
Okay, so when you say partial hip replacement, you're replacing the ball and you're leaving the socket?
Right. The assumption is that unless the person had pre-existing bad wear of the cartilage in their hip cup, that's okay. So the ball is broken, so you're removing it, and you're replacing it with another metal ball that'll just fit right into the socket like your own hip did previously.
Okay, so that's my summary teaching on fractures. Now what about when a person does not have a hip fracture, or their hip joint or their knee joint sort of gets worn out, or in other words suffers from degenerative joint disease? Now can you also replace the acetabulum or the cup? You call it kind of like the ball and joint or ball and socket.
Right. So when somebody has chronic arthritis, it's something that's bothered them for a long time, it typically will wear both surfaces, the ball and the lining of the cup. And they're both cartilage surfaces and they both hurt. So if we were to go into a patient like that and replace just the ball, they'd still have pain from the roughened cartilage on the cup. So typically with people who have long-term arthritis who need a hip replacement, we do replace the ball, and then we put a liner into the cup, and that acts as the bearing surface so that the new ball is not rubbing on the old cartilage.
Okay, so what we call the cup is called the acetabulum, is that correct?
Correct.
So the head of the femur, in other words, the very top part of the thigh bone has the ball, and there's a portion in the pelvis that has the cup or the acetabulum.
Correct.
So you can change both of those.
You can.
With degenerative joint disease.
Right.
And I think you meant to teach me and us that sometimes with fractures you can replace the ball, but you don't have to replace the cup. Is that correct?
Right. So in that case, you are assuming that, again, that the cartilage is adequate in the cup to bear the weight of the new metal ball that's put in when you replace just the ball in some hip fractures.
Okay. So in the few minutes that we have today, can we talk briefly about the knee joint?
Sure.
Now, the knee is also made up of very large bones. That's the sort of bottom of the femur, right? And also the very top of the tibia, a little bit of the fibula perhaps. So why does that suffer from degenerative joint disease? Is it same as the hip, or different than the hip?
It's pretty much the same as the hip, but its function is a little bit different. The forces that go across the knee joint, if somebody ends up having a little bit of a bend, a little bit bow-legged, a little bit knock-kneed, it concentrates the forces then on one portion of the knee joint, one edge or one side. So some people who are bow-legged oftentimes will have pain on the inner part of their knee. People who are knock-kneed tend to have pain on the outer part. And that concentration of that force can really wear the cartilage quickly. So we see, as just an analogy to fractures, we see in people who've had trauma to their thigh bone or to their leg bone, oftentimes if it leaves them with a deformity of their leg, they'll get arthritis earlier in their joint, because that bend now that they have in their limb concentrates the force in one area more so than it would have prior to the fracture.
Okay. Now, Dr. Meckel, I finished my medical school at the University of Vermont, big ski country, and I remember my professor of orthopedics talking about skiers rupturing their cruciate ligament. And even though the cruciate ligament was repaired, the anterior cruciate ligament, sometimes he would tell the patient that in 20 or 30 years, they may be a candidate for a joint replacement, because you guys try to fix things back up perfectly, but there can be even, say, a half a degree difference or a little shift, which may lead to wear and tear. Isn't that correct?
Yep, it's actually pretty dramatic. The theory there is that the leg bone and the thigh bone meet at the knee, and there's probably a normal amount of motion that occurs there as you're exercising and doing activities. But if you injure that ligament that tethers that, then you have more motion, and the belief is that then, because there's more motion, you wear the cartilage earlier. And nowhere is that concentration of force issue probably more evident than in the ankle joint, which we don't need to get into, but if that ankle joint is off just a little bit, it really accelerates the arthritis in the ankle quickly.
It's amazing to me the number of analogies, it sounds to me anyway, between a fine automobile and an engine and the certain joints and the lubrication and the glistening surfaces. Sounds to me like a car engine, even if it gets out of kilter just barely, in a few thousand miles, you could need a valve job or a piston job, etc.
Right. It's yeah, the analogies are pretty amazing actually between just mechanical things and the human body. The benefit we have is that we can regenerate things sometimes.
Dr. Meckel, we only have about 90 seconds left. I'd like to give out your phone number and your website. You're here in Monterey, you're at Ryan Ranch, and your group is called Monterey Spine and Joint, correct? You have a website?
We do. It's montereyjoint.com.
montereyjoint.com. And your phone number?
Is 648-7200.
Perfect. Dr. Christopher Meckel, you're board-certified orthopedic surgeon. You've done a fellowship in joint replacement.
Correct.
831-648-7200, montereyjoint.com. We just have a few seconds few seconds remaining. Now, just briefly, the shoulder joint can be replaced, can be repaired.
Sure, the shoulder joint can, there are replacements for arthritis of the shoulder joint. The shoulder joint is is less of a dependent joint. It hangs down, so we don't see it wearing out as much, whereas the hip and the knee, there's more compressive forces. So shoulders tend to last longer. But all the same things that are applied to the hip and the knee in terms of replacement can be applied to the shoulder, and certainly there's other problems with shoulders that can be fixed surgically as well if needed.
Well, that reminds me of when I do joint replacements in the hand, motion is vital, but the hand doesn't have to bear weight. Very similar, it sounds like very similar to the shoulder, is that correct?
Right, right. So shoulder replacements can do very well over a long period of time because they don't, the components that are in there don't wear as quickly.
Dr. Christopher Meckel, board-certified orthopedic surgeon. I'm delighted to bring you back on. I hope you come again. This stuff is fascinating to me, and I always like the segments where I learn a lot. Thanks for being here.
Thanks for having me. I appreciate it, David.
Once again, this is Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and we're going to take a very brief pause for a very good cause. Thanks so much for being here.